What are the most important skills a medical surgical nurse should have?
In my view, a medical surgical nurse requires a truly comprehensive and dynamic skill set to excel in such a diverse and demanding environment. At the core, exceptional clinical competence is paramount. This encompasses a robust understanding of pathophysiology across a wide range of medical conditions and surgical procedures, enabling precise patient assessment, accurate vital sign interpretation, and the ability to anticipate and respond to subtle changes in a patient's condition. Administering complex medications safely, managing various drains and lines, and performing meticulous wound care are daily necessities, all underpinned by strong critical thinking to prioritize interventions and make sound clinical judgments, often under pressure. Beyond the technical aspects, effective communication is equally vital. A medical surgical nurse must be adept at conveying complex medical information to patients and their families in an understandable and empathetic manner, ensuring they feel heard, informed, and involved in their care plan. This also extends to seamless interdisciplinary communication with doctors, therapists, and other nurses, fostering a collaborative environment essential for holistic patient outcomes. Building rapport and trust is fundamental, as is providing compassionate emotional support, particularly when patients are facing significant health challenges or difficult prognosis. Furthermore, superior organizational skills and adaptability are indispensable. Medical surgical units are fast-paced, with nurses often managing multiple patients with varying acuities and needs simultaneously. The ability to prioritize tasks efficiently, manage time effectively, and anticipate potential issues is crucial for maintaining patient safety and meeting care demands. Moreover, the capacity to remain calm and flexible in rapidly changing situations, such as a sudden patient deterioration or an unexpected admission, demonstrates resilience and professional composure, ensuring high-quality care is consistently delivered regardless of the circumstances. These combined attributes allow a medical surgical nurse to navigate the complexities of the role with confidence and precision.
Describe a time a patient's pain assessment didn't align with their physical presentation on the Med-Surg floor. How did you investigate and manage this discrepancy?
On one occasion, I cared for a patient on the medical surgical floor, Mr. David, a 65-year-old gentleman who was 2 days post-cholecystectomy. When I asked him to rate his pain, he firmly stated it was a 10 out of 10, which typically indicates excruciating, incapacitating pain. However, his physical presentation didn't quite align with this assessment. He was calmly watching television. His vital signs were stable and within normal limits, and he was able to shift position with minimal grimacing. This significant discrepancy prompted immediate investigation. My initial step was to delve deeper into his pain experience. I sat with him, asking open-ended questions like, "Can you describe what a 10 feels like for you right now? And what makes it a 10 instead of an 8? I gently inquired about his past experiences with pain and pain medication, noting any underlying anxiety or fear that might be amplifying his perception or expression. I also observed his nonverbal cues more closely, looking for subtle guarding or discomfort that I might have initially missed. A quick review of his chart showed no prior history of chronic pain, which helped rule out certain complex pain conditions. To manage this discrepancy, I first validated his reported pain, saying, "I understand that you're feeling an immense amount of pain, and I want to help you feel more comfortable." I then explained that while his body wasn't showing typical severe pain signs, his discomfort was still real to him. We discussed strategies. I offered repositioning, a warm compress, and guided breathing exercises first. I also clarified the pain scale with him, ensuring his understanding. After these non-pharmacological interventions, if he still reported a 10/10, I would then consult with the physician for further assessment, potentially exploring a lower dose of pain medication or an anxiolytic if anxiety seemed to be a significant factor, always prioritizing his comfort and safety. This approach ensured his pain was addressed while also maintaining a holistic view of his condition.
When assessing a postoperative patient, what are the 3 most critical findings you look for that would immediately trigger you to escalate care to the physician?
When assessing a postoperative patient, 3 critical findings would immediately trigger me to escalate care to the physician. Firstly, any sudden and significant deterioration in vital signs is a major red flag. This includes persistent hypotension, an unexpected and sustained tachycardia or bradycardia, a rapid increase in respiratory rate with associated difficulty, or a sudden, unexplained drop in oxygen saturation. Secondly, acute neurological changes demand immediate attention. This would involve any sudden alteration in the patient's level of consciousness, new-onset disorientation, severe confusion not present before, or the development of new neurological deficits, such as unilateral weakness or vision changes. Lastly, uncontrolled hemorrhage or signs of major fluid shift are paramount concerns. This presents as excessive and bright red bleeding from the surgical site, unexpected and rapid swelling, or systemic signs of hypovolemic shock like cold, clammy skin, pallor, and persistent low blood pressure despite fluid resuscitation. These findings suggest acute, potentially life-threatening complications requiring urgent medical intervention.
When administering a medication you've never given before on a busy medical surgical shift, what specific resources or steps do you rely on to ensure complete patient safety, beyond just confirming the 5 rights?
When encountering a medication I've never administered before on a busy medical surgical shift, my immediate focus shifts to a multi-layered approach to ensure absolute patient safety, extending well beyond the standard 5 rights. My first crucial step is to access a reliable, up-to-date pharmacology reference, typically an electronic drug guide or the hospital's comprehensive formulary. I meticulously review key information, including its mechanism of action, precise indications for use, contraindications, and the full spectrum of potential side effects, distinguishing between common and severe reactions. Crucially, I focus on specific nursing considerations, what assessments are required before, during, and after administration, specific dilution instructions, safe infusion rates if it's in 4 medication, and any critical monitoring parameters like laboratory values or vital sign trends. Simultaneously, I always consult the patient's electronic medical record thoroughly to cross-reference the medication order with their current medical history, existing medications to identify potential interactions, and their latest lab results, which might influence drug metabolism or excretion. This detailed review helps me contextualize the medication within that specific patient's unique physiological profile. Beyond digital resources, consultation with experienced colleagues or the unit pharmacist is invaluable. A quick conversation with a peer who has experience with the drug can offer practical tips or highlight subtle nuances not always captured in a text. For high-alert medications, or anything particularly complex, directly speaking with the pharmacist provides an essential layer of verification and clarification on preparation, stability, and administration. Finally, I engage the patient in their care by providing clear education about the new medication, explaining its purpose, what effects to expect, and what potential side effects to immediately report. This not only empowers the patient, but also serves as an important safety net, as they often become the first alert system for adverse reactions. This comprehensive strategy ensures that even amidst a busy shift, patient safety remains my unwavering priority.
Tell me about the specific brand names of the most common 4 pumps, telemetry systems, or wound vac devices you routinely operated in your previous medical surgical setting. Describe a common troubleshooting issue you faced with one of them.
In my previous medical surgical setting, we routinely operated a range of essential equipment. For 4 pumps, the BD Alaris system was our primary workhorse, often complemented by Baxter Sigma Spectrum pumps, particularly for specialty infusions. Our telemetry monitoring was predominantly handled by Philips IntelliView systems, which provided continuous cardiac rhythm surveillance for our patients. For advanced wound care, the KCI VAC therapy units were the standard devices we utilized for negative pressure wound therapy. A common troubleshooting issue I frequently encountered, especially with the KCI VAC therapy units, were persistent leak alarms. This alarm indicates that the system is unable to maintain the prescribed negative pressure at the wound site, which compromises the effectiveness of the therapy. When this occurred, my immediate steps involved a systematic assessment of the entire dressing and tubing system. First, I would visually inspect the entire dressing, including the transparent film, for any visible tears, wrinkles, or areas where adhesion might be compromised, particularly around irregular contours of the body. I would then check the tubing connecting the dressing to the canister and the canister to the pump, ensuring there were no kinks, occlusions, or disconnections. Often, a minor wrinkle in the drape or a partially dislodged tubing connection was the culprit. If a leak was identified, I would meticulously reinforce the seal with additional transparent film, ensuring at least a 3 to 5 centimeters overlap around the edges of the original dressing. I would also confirm that the foam dressing underneath was adequately filling the wound bed and that the Synsat.RAC pad was correctly positioned without being compressed or kinked. If these basic troubleshooting steps didn't resolve the alarm, I would then consider changing the entire dressing, especially if the original one had been in place for several days or if the leak was significant and unidentifiable. This systematic approach usually resolved the leak and restored the therapeutic negative pressure.
Walk me through your detailed process for assessing and managing a patient admitted with fluid overload on your ward. What specific parameters do you prioritize monitoring?
When a patient is admitted with fluid overload on my ward, my approach is systematic and detail-oriented, prioritizing specific parameters to ensure comprehensive assessment and effective management. My initial assessment immediately focuses on their respiratory status. I'm looking for signs of dyspnea, orthopnea, or increased work of breathing, and I'll auscultate their lungs meticulously for crackles or rales, which signify pulmonary edema. Alongside this, I constantly monitor their oxygen saturation levels. Concurrently, I shift to their cardiovascular status. I assess heart rate and rhythm, check blood pressure for any trends, and critically evaluate for jugular venous distension, JVD, as an indicator of increased central venous pressure. I also examine for peripheral edema, noting its location, extent, and whether it's pitting. Strict intake and output, I&O, measurements are then implemented immediately, and a daily weight is obtained at the same time each morning using the same scale, as this is the most reliable indicator of fluid status changes. Renal function is monitored through hourly urine output and trending blood urea nitrogen, BUN, and creatinine levels. My management strategy, informed by these assessments, begins with notifying the physician promptly to discuss findings and receive orders. I will then administer diuretics as prescribed, closely monitoring their effect on urine output and symptom resolution. Strict fluid restriction is a crucial component, requiring clear patient and family education on permissible fluid intake. I ensure the patient is positioned comfortably, typically with the head of the bed elevated, to ease respiratory effort. Skin integrity is also a concern with edema, so I implement meticulous skin care to prevent breakdown. Throughout this entire process, continuous, vigilant monitoring of all these prioritized parameters, meticulous documentation, and ongoing patient education about their condition and treatment plan are paramount. I collaborate closely with the medical team, ensuring a cohesive approach to effectively resolve the fluid overload and prevent complications.
How would you react to a significant drop in a patient's pulse oximetry reading?
If I observed a significant drop in a patient's pulse oximetry reading on my medical surgical ward, my reaction would be immediate and systematic, prioritizing patient safety above all else. My very first action is to assess the patient directly, not just the monitor. I would quickly check their level of consciousness, observe their respiratory effort for any signs of distress like increased work of breathing or accessory muscle use, and assess their skin color and capillary refill. Simultaneously, I would ensure their airway is patent and listen to their lung sounds for any abnormalities such as crackles, wheezes, or diminished breath sounds. While this rapid assessment is ongoing, I would also troubleshoot the equipment. I'd ensure the pulse oximeter probe is correctly placed, checking for common issues like patient movement, poor perfusion to the extremity, e.g., cold fingers, or the presence of nail polish that could interfere with the reading. Often, simply repositioning the probe or moving it to a different digit can resolve a falsely low reading. If the reading persists, I try a different probe or even a different monitoring device to rule out equipment malfunction. Concurrently with my assessment and troubleshooting, I would initiate immediate interventions. I would elevate the head of the bed to a comfortable position to promote lung expansion and ease breathing. If the patient is on supplemental oxygen, I check the flow rate and ensure the oxygen delivery device is properly applied. If not, and the desaturation is significant, I would prepare to administer oxygen as per hospital protocol or a standing order, while simultaneously preparing to escalate care. I would immediately notify the physician with my complete assessment findings: the new SpO2 reading, the patient's respiratory rate, work of breathing, lung sounds, and any changes in their mental status. Depending on the severity and the patient's response, I would be prepared to activate the rapid response team, ensuring continuous monitoring and support for the patient until their condition stabilizes or further medical orders are received.
You've just received a handoff report, but during your initial patient assessment, you discover a new, significant change in condition not mentioned. What is your immediate course of action and communication strategy?
Discovering a new, significant change in a patient's condition immediately after receiving a handoff report requires a decisive and methodical approach, prioritizing patient safety above all else. My immediate course of action is to thoroughly assess the patient myself to verify the finding and determine its urgency. This means quickly performing a focused assessment related to the observed change. For instance, if it's a new neurological deficit, I'd conduct a rapid neurological exam. If it's acute pain, I'd assess its characteristics and the patient's current status. The goal is to gather objective data and understand the potential implications for the patient's immediate well-being. Concurrently with this assessment, my communication strategy begins. If the finding indicates an acute, potentially life-threatening situation, like sudden respiratory distress, new-onset altered mental status, or significant active bleeding, my first call is to the treating physician, using a concise SBAR, situation, background, assessment, recommendation, format to convey the critical information clearly and efficiently. I will describe the new change, the patient's baseline from the report, my current assessment findings, and suggest immediate interventions if appropriate. Once the physician is aware and initial interventions are underway to stabilize the patient, my next communication step is to address the discrepancy with the nurse who provided the handoff report. This conversation would be conducted professionally and privately, focusing on collaborative patient care rather than blame. I would calmly state, during my initial assessment of Mr. Peterson, I noted a new onset of facial drooping and slurred speech. I just wanted to touch base with you, as it wasn't something mentioned in report, and I've already notified the physician. The aim is to ensure continuity of care and to understand if the change developed very recently, was subtle, or if there was an oversight in the report. This approach fosters a culture of safety and shared responsibility, ensuring all team members are aware of critical patient status changes. Throughout, meticulous documentation of all findings, interventions, and communications is paramount.
If you noticed a consistent pattern of post-surgical patients at our hospital experiencing prolonged nausea and vomiting, how would you approach identifying the root cause and proposing a solution?
If I observed a consistent pattern of post-surgical patients experiencing prolonged nausea and vomiting on our ward, my immediate approach would be to treat this as a significant quality improvement issue, initiating a structured process to identify the root cause and propose sustainable solutions. Firstly, I would begin with a comprehensive data collection and analysis phase. This would involve reviewing patient charts to confirm the pattern across different surgical specialties, identifying specific anesthetic agents used, the types and doses of perioperative medications, especially opioids and antiemetics, patient demographics, age, gender, history of motion sickness or previous PONV, and the duration and severity of the nausea and vomiting. This detailed review would help to pinpoint commonalities and potential high-risk patient groups or procedures. Concurrently, I would initiate multidisciplinary collaboration. This is crucial for a systemic issue like this. I would engage directly with the anesthesia department to review their protocols for PONV prophylaxis and treatment, as well as the types of anesthesia utilized. Discussions with surgical teams would focus on specific surgical techniques or durations that might contribute. I would also involve the pharmacy for insights into medication availability and best practices, and the nursing team to discuss assessment consistency and current management strategies on the floor. Based on the gathered data and discussions, I would aim to identify key contributing factors. Hypotheses might include inadequate antiemetic prophylaxis protocols, an over-reliance on emetogenic opioid pain control, or a lack of standardized PONV risk assessment preoperatively. To propose solutions, I would advocate for evidence-based protocol revisions. This could involve implementing a standardized PONV risk assessment tool for all surgical patients, allowing for tailored, multimodal antiemetic regimens based on individual risk scores. We might explore optimizing pain management strategies to reduce opioid consumption where feasible, or incorporating non-pharmacological interventions consistently. Education for all relevant staff, nurses, anesthesiologists, and surgeons on these new protocols and the latest best practices for PONV prevention would be essential. Finally, I would propose a system for ongoing monitoring and evaluation to track the incidence and severity of PONV after implementation, ensuring the effectiveness of the new solutions and fostering continuous quality improvement.
Tell me about a specific instance where you identified a potential fall risk that was not immediately obvious and what proactive interventions you implemented to prevent an incident.
One specific instance where I identified a subtle fall risk involved a 72-year-old patient, Mr. Henderson, on our medical surgical ward. He had been admitted for pneumonia and was making good progress, ambulating with a walker down the hallway earlier in my shift. However, during my late afternoon rounds, I observed him attempting to reach for his water glass on his bedside table, and instead of using his call bell or waiting for assistance, he leaned precariously far over the side of the bed. His usual, steady movements seemed slightly uncoordinated in that moment, and he grimaced subtly. Objectively, his pain score was still low, and his vital signs were stable, so on paper, he didn't fit the typical high-risk fall criteria at that precise moment. What struck me was the combination of his uncharacteristic reach, the slight unsteadiness, and the brief grimace, which suggested he might be experiencing new, low-level fatigue or weakness, possibly related to his ongoing recovery from pneumonia. Recognizing this as a potential change in his baseline mobility and judgment, I immediately intervened. I first repositioned his water, call bell, and other personal items within easy reach to eliminate the need for him to lean. Then, I initiated a more in-depth conversation with him, asking about his energy levels and if he felt any new dizziness or weakness, even mild. He admitted to feeling a bit more tired than usual. Based on this, I updated his fall risk assessment, increasing his score, and implemented a proactive toileting schedule to reduce his need to get up unassisted. I also placed a non-slip mat beside his bed and ensured his bed alarm was activated at a lower threshold. I communicated this change in his status and the new interventions to the oncoming nurse during handoff. Thankfully, no fall occurred, and he continued his recovery smoothly.